Hello everyone, I'm Nicola Boydell from the University of Edinburgh, and today I'll be talking about co-design in abortion and contraceptive services and what this reveals about how we can meaningfully involve people in shaping healthcare. I'll be drawing on work from my This Institute Fellowship and from a recent project funded by the Scottish Government seeking to co-design post-abortion contraceptive services in Scotland. My aim is to share practical insights from doing this work, but also to make a broader point that abortion care challenges and extends dominant assumptions about co design practices and processes. Co design is now widely recognised as good practice in healthcare improvement. It means working with people who use and deliver services, not designing for them at a distance. And just to ground us in the same definition and ensure we're talking about the same thing, when I say co-design, I mean approaches that bring people with lived experience and people delivering services together to jointly shape care and research. This is not simply about consulting with people or collecting feedback, but about sharing power and working together to design research and to design services. And we see really good evidence for the value of co design in a number of different areas of healthcare. For example, maternity services, mental health care, and support for chronic and long term conditions. What's interesting about those spaces is that often people have ongoing relationships with services and established patient communities and support networks. And that type of organisation and involvement can make practices of co design more straightforward because there's infrastructure to help participation. Abortion care looks really quite different from that. It's typically a brief or one off interaction with the healthcare system, and it's deeply stigmatised. One of the things that makes abortion care different is that there isn't a cohesive abortion care identity or abortion care patient group. People often move on after treatment and move on quickly for understandable reasons. So we face a few key questions. How do we meaningfully involve people in designing abortion care when traditional participation structures simply don't exist? And that leads to a second question. What does abortion care help us learn about the limits and the possibilities of co design? These questions shaped my fellowship on abortion care futures. In the project, I worked with abortion care providers, community partners and organisations, other researchers, activists, and people with lived experience. And what I wanted to do with these people was to understand what meaningful involvement looks like and how we can do it in a politicised, stigmatised, and often fragmented healthcare system and context. This wasn't just about new service ideas or models, it was about testing the use of participatory approaches in spaces where involvement is not easy. And that would help us, or that would help us to understand what co-design requires in these settings. One of the key elements of this fellowship project was bringing people together with community organisations, abortion care providers, researchers, activists, and people with lived experience to undertake some participatory mapping. Now, don't worry about trying to read every word on this slide. What I want to show you is the process and why it mattered. So we began with messy post-its on notes and on walls and on tables, capturing everything participants identified as important: people, services, policies, legal influences, sociocultural contexts, moments of care, and power dynamics. And through this workshop, we worked together to turn that mess into a more organised system map, which you can see on the screen here. And then we synthesised that representation of the abortion care landscape into something more detailed. We didn't start with a fixed definition of the system. Instead, we built it layer by layer. And this is important because in highly politicised areas of care, the system isn't neutral. What counts as a stakeholder or as an interested party is itself contested. And what this map reveals is a complex landscape spanning healthcare, legal systems, policy systems, community organisations, digital spaces, and sociocultural contexts. And it means that there's multiple entry points for engaging with people and communities and organisations to develop knowledge in this area. And it also helps to identify where involvement and participatory approaches currently break down. The act of mapping together made visible not only the formal structures, but also the informal and other structures that shape uh, abortion care in Scotland and beyond. And this was important because once we'd done this and we had made it visible, we could collectively identify opportunities for involvement, relationships we could help to strengthen, and hidden points of vulnerability, as well as areas where power and stigma and legal restrictions can constrain opportunities for involvement and engagement. So, from this work, we identified barriers that are rarely foregrounded in the co design literature currently. And that is the impact of diverse socio political views on co design processes, restrictive laws and the way that laws interact with healthcare systems to make it more or less easy to do co design work, the impact of stigmatizing processes and socio-cultural expectations around particular forms of healthcare, in this case abortion, the way that there's no a cohesive abortion identity or community patient group in this area, the perceived political risks for organisations for engaging in supporting work around abortion care, and the lack of shared definitions around contraception and abortion. Where does contraception end and abortion begin? Together, these issues made it clear co design isn't context free, it's shaped by politics, stigma, law, and identities. And abortion care exposes those pressures very clearly. But despite these challenges, I would argue that involvement and participatory approaches in this area of care are essential. Abortion care intersects with healthcare, but also with other domains, as I've highlighted through the landscape map. Community organisations, education, the law, and cultural and religious contexts. You can't understand abortion care only by looking at the clinic. Without the meaningful involvement and lived experience, we risk designing in the dark. What involvement does is it creates accountabilities, surfaces new insights, and pushes services towards more equitable and just forms of care. It's an ethical commitment. So, the SCOPE project, which was funded by the Scottish Government, put these insights from my fellowship work into practice in Scotland. Over a 20-month period, we sought to bring together community organisations, abortion care providers, and people with experience of abortion and contraception to co design approaches to the delivery of post abortion contraception. We did this by synthesizing evidence and working with people collaboratively to design flexible services. The outcome of this wasn't a single model, and that's important. Instead, we designed flexible, needs led models that acknowledged resource constraints, acknowledged workforce pressures, took into account diverse settings, both rural and urban, and that acknowledge and seek to address the persistent inequalities in access to abortion care that we see in Scotland. While it wasn't easy and we encountered a range of challenges, what Scope did was show that co design can work in episodic, resort stretched services when we design with those realities and not despite them. So, what does all of this tell us? Well, I would argue that abortion care is a critical case for co design. It advances theory and practice by helping us to address the assumptions about patient identities and groups and to recognise the impacts of the political risks to communities and individuals within the abortion care landscape and beyond. It reminds us that co design isn't a toolkit only of methods, it's a way of working that needs to be contextual, flexible, and justice orientated. And for me, as someone working in abortion and contraceptive care, there's real urgency to this work. Sexual and reproductive rights are increasingly under threat in the UK and globally. Co design offers an important approach to building care that works with people who use and deliver it, and that is equitable, evidence informed, and focused on advancing sexual and reproductive rights. So, the challenge I want to leave you with is fairly simple. If co design works in other areas of healthcare, why not here? And what will it take to change the story about co design in abortion and contraception? Thanks.